Good day. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today we have the third in a series of the ACNS skull base series, and Dr. Sampath Chandra Prasad from Bangalore, India, is going to give a presentation on lateral skull base basics. And before we turn it over to Sampath, let's do what the powerful thing about this platform is: network and meeting everybody. I want Sampath to meet everybody and everybody to meet Sampath. So when I introduce yourself, please unmute yourself, give your name, where you work, and we'll go on. Okay, let's start with Warlix. Hi, Warlix.
Hi, สวัสดีค่ะ Dr. Sampath. Yeah, I used to listen to your lecture before in Thailand.
Oh, wonderful.
Welcome.
Nice.
Welcome.
Again,
I record your lectures at that time. It's wonderful.
oh,
But,
thank you. Thank you.
You prepared it so nice, but they gave you short time to present.
Oh, yes. It was an event where there were plenty of lectures and all of us had to speak for about 15 minutes. But it was interesting.
But it's a difficult chapters too, that one. But you have a lot of details that I like to know. And oh my God, this time is too short.
Okay, very good.
Yes.
Okay, let's meet everyone else. Let's try Marquez. Are you there, Marquez, to introduce yourself? Okay, we'll go on to Sunil. Sunil, are you there? He looks like he stepped away. He's from China. Ahmed, hello, welcome, Ahmed Al-Jadi. How are you doing? Could you please introduce yourself? Ahmed?
Est-ce que son état d'esprit s'applique ou pas?
Well, I guess his screen's froze. Yeah, okay. AB, could you please introduce yourself?
Je peux voir l'image de son scanner.
Okay, I'm going to try to unmute you. Go ahead, AB, go ahead. We can't hear you there, Ahmed. Well, I guess there's a problem there. AB, try again. Your microphone is not on, I guess. It was before. Well, that's okay. I guess we'll meet you. AB is a neurosurgeon from Indonesia.
Wonderful, AB. Nice to meet you.
Great. Nuru.
What?
Hello.
Yes?
Could you please introduce yourself?
Hello.
Yes.
Okay.
Could you
Good
please...
morning, Professor. I'm Nouruddin Bankole. I'm come from Benin, but I'm studying WFNS Rabat Center. I'm in my third year of residence course. And nice to meet you. And I know you. I read some paper of you. And I'm very happy to meet you this morning.
Same here. It's a pleasure meeting all of you. It's a pleasure knowing you all, and I'm sure we will meet in person sometime very soon.
Yeah.
And I hope that will happen soon. And yes, I organize courses back in Bangalore as well. So you're welcome to attend one of my courses if time permits. And yeah, I look forward to meeting you. Yes.
Okay, Sampath, I'd like you to meet Sunil from China. Hello, Sunil.
Hi, thank you.
Go ahead, Sunil. Go ahead. Introduce yourself, please, to Sampath.
Hi, Sunil.
Hello, everyone. I'm Sunil. Hometown is from Nepal, but currently, I'm in China, doing my PhD in neurosurgery.
Welcome, Sunil. And AB, you're back. Can you try again, please? Introduce yourself, AB. Are you there, AB? Oop, I cannot unmute you. Okay, Manuel, could you please introduce yourself?
Hello, everyone. My name is Manuel. I'm from the Dominican Republic. Right now, I am making the resident of neurosurgery in Moscow. Nice to meet you.
Okay,
Nice to meet you, Manuel.
welcome, Manuel. Ulrich, are you there? Could you please introduce yourself?
Yes. Hi, I'm Ulrich Sidney, final-year medical student in Cameroon.
Hi, Ulrich. Nice to see you.
That's great. Medical student from Cameroon. That's fantastic. Ahmed, is your audio okay? Can you introduce yourself, Ahmed?
Hello, everyone.
Go ahead, Ahmed.
Hi, Ahmed.
Hi, everyone. I'm Dr. Ahmed Jaradi, neurosurgeon from Yemen.
From Iran.
Recently.
Excellent. From Iran. Excellent. Rakesh.
Hello, everyone. I'm Dr. Rakesh Evi, a neurosurgery resident from India. Sorry for the video, I'm not there. I'm very eager to listen to Chandra. I keep seeing your class courses advertisement in Bangalore, and very nice to see you, sir.
Very
Hi,
good.
Rakesh. Good to hear from you. And yes, I'm very close by. I guess we should meet.
Yes, sir. Really. Thank you so much. Thank you so much.
Thank
Very good. Ravi Sango, could you please introduce yourself? Ravi, are you there? Maybe not. We'll move on to Deepak Bengal. Hello, Deepak. Are you there?
Hi, sir. Yeah, I'm here. Dr. Deepak from Medanta, the Medicity. I'm a consulting neurosurgeon in Medanta, Delhi. Nice to meet you, sir.
Nice to meet you, Deepak.
Welcome, Deepak. Tanmay, are you there? Tanmay? Tanmay?
I'm Tanmay. I'm doing my final year neuro residency in India.
Okay, welcome, Tanmay.
Hi, Tanmay.
Hi, nice to see you, sir.
Nice to meet you too.
Okay, Galaxy Pro. I think that's a neurosurgeon from Cameroon, also, right? Okay, I think I can't identify that person. Okay, I'd like to welcome Sampath. He can introduce himself and what he's done, and then go on to his presentation. Welcome, Sampath.
Thank you, John. I'll go on to my slides, I guess, and then talk a little bit of myself. Is my presentation on the screen right now?
Yes, it is. Perfect.
Okay, great. So yes, my name is Sampath Chandra Prasad Rao, a longish name, but I'm from India. Most Indian names are quite long, but all of you can call me Sam. Most people who know me call me Sam, and it's a pleasure, an honor, and a privilege to be with all of you, and to be talking to you, to be knowing all of you. It's a new circle for me. I've not seen most of you, and it's always nice to meet new people, make new friends, and I hope to see all of you in person one of these days. I am right now on my bed, and this is where I am on most of the day on a Sunday. So it's the most comfortable place on earth for me, probably my second most comfortable place on earth, because the first one obviously would be in an operation theater, and I guess I should say that this is the second most comfortable place on earth for me. So I'm very comfortable on my bed, talking to you. I'm pretending to be a little formally dressed. I'm just putting a coat on just to give it a little bit of a formality. But yes, I'm all prepared to take you through the topic that was allotted to me, that is to describe some of the trans-temporal approaches to the lateral skull base. As all of you know, the world is moving fast towards specializations, and in neurosurgery, in ENT, in head and neck surgery, I think skull base has carved a niche for itself, and most centers who do serious skull base work focus on skull base as a separate specialty, and I think that's the way forward. Skull base surgery is, I always say that skull base surgery has three distinct territories. One is the intracranial territory, one is the temporal bone territory, and the upper neck or the upper infratemporal fossa territory. So these three territories actually comprise make up what is the field of skull base surgery. And yes, skull base surgery can also be subdivided into anterior skull base, lateral skull base, and people often specialize in either one of these areas, or sometimes both, depending on the kind of practice one prefers. But yes, skull base surgery is fast developing into a very, very niche area.
Excuse me, Professor, your slides aren't moving. Do you want to move the slide?
Yes, I will go to the, I'm still with the first slide.
Okay, I'm sorry
yes.
to interrupt. Go ahead.
Yes, so I work in Bangalore. I was trained in skull base surgery under Professor Mario Sanna, who was from Italy, and who's got one of the largest series of skull base cases published in English literature. So I was with Professor Mario Sanna for close to 6.5 years, first as a fellow and then later as a member of the group. So I've put the logo of the group as well. But right now, I'm in Bangalore. I've moved down to India, and I work in two of the important corporate hospitals in the city. One is Manipal Hospital, and the other one is Columbia Asia. So now my slides don't move. Okay. Oh yeah, there it goes. Okay, so this is the territory that we're going to deal with today. I was told that I have 1 hour for this lecture, and I thought the most apt thing would be to deal with the surgical approaches. And I see a lot of you are neurosurgeons, and you know, the trans-temporal approaches are not the most familiar approaches for neurosurgeons. So I thought I'll quickly go through the steps of 3 or 4 of the most important trans-temporal approaches. Now, this is the territory that we're dealing with. Can you see my pointer? Is my pointer visible?
Go ahead again. Oh, yes. Well, yes, you can see it. Yes, we can see it.
Yes. Okay. Yes. So, so this is the undersurface of the skull base. All of you would be familiar with this area. Now, let me quickly take you through the anatomy of the lateral part of the lateral skull base. So this is the mastoid tip. The digastric ridge is here. This is the place where the tendon of the digastric muscle inserts itself. Now, if you can see that the digastric muscle tendon points directly to the facial nerve. This is the stylomastoid foramen coming out of the facial nerve, and the facial nerve is one of the most important structures in the lateral part of the lateral skull base. So this is the stylomastoid foramen, and just anterior and medial to the stylomastoid foramen is the styloid process. So if we're coming from laterally from the neck, you would want to identify the styloid process and then look for the facial nerve just lateral to the styloid process. Now, medial to both these structures is the jugular foramen, which has the vascular compartment and a neural compartment. So this is the jugular foramen, and medial to it is the carotid canal. This is the entry of the transition zone between the parapharyngeal carotid and the petrous carotid. So this is the entry of the carotid canal in the petrous part of the temporal bone. This is the canal for the hypoglossal nerve. It's partly hidden by the occipital condyle, and but you can actually see the canal going traversing the occipital condyle. Now, this is a lateral view of the same area. I always say that the tympanic bone is perhaps the gateway to lateral skull base. So if you're coming from laterally, if you're doing one of the trans-temporal approaches, it's very important for you to remove the tympanic bone in toto. The more you remove the tympanic bone, the more structures you expose deeper down. The tympanic bone is a small bit of bone. You can see my pointer moving along the bone. This is the external auditory canal. This is the tympanic bone. It has 3 suture lines. The tympano-squamous suture line, because it corresponds to the squamous portion of the temporal bone. The tympanomastoid suture line, corresponding to the junction between the tympanic bone and the mastoid portions of the temporal bone. And the tympanopetrous suture line, which corresponds to the junction between the tympanic bone and the petrous parts of the temporal bone. Now, removing this bone in toto would mean that you would expose the carotid canal laterally, the jugular bulb, and also the facial nerve. So this wedge of bone here is the tympanic bone, and removing this wedge of bone would expose the stylomastoid foramen, the lateral part of the jugular foramen, and also the lateral wall of the carotid canal. So that's the reason why drilling out this bone in toto, and of course the styloid process also is attached to the tympanic bone. So removing all this would give a very nice control of the structures more medially. And you can see the jugular foramen here, and deeper down you can see the hypoglossal canal traversing the occipital condyle, and this is the area where the carotid gets into the petrous portion of the temporal bone. Further anteriorly, you could add a craniotomy or drill through this root of the zygoma to go a little more anteriorly into the infratemporal fossa. And in fact, by adding a subtemporal craniotomy, one can go all the way up to the sphenoid sinus. Now, this is how it would look when the canal wall is brought down. This is when the canal wall is intact. When I say the canal wall, I mean the posterior canal wall, the posterior external auditory canal wall. This is when it's intact. This is when it's brought down. Most structures are visible as you remove the posterior canal wall. The middle fossadural plate, sigmoid plate, posterior fossadural plate are all exposed to get into the deeper structures. Then by rerouting the nerve anteriorly, you see now I've gone deeper and rerouted the nerve anteriorly. By rerouting the nerve anteriorly, you could then get into the more posteromedial aspects of the temporal bone. This is the jugular bulb. This is the sigmoid sinus, jugulosigmoid complex, the 11th cranial nerve, carotid, and the hypoglossal nerve. All these areas that are well within control once the facial nerve is rerouted anteriorly. Now, by opening up the dura and getting into the CP angle, you could convert a trans-temporal approach into an intracranial approach. So you saw the cranial nerves getting into the medial wall of the. Now here the jugular bulb has been taken out. The medial wall of the jugular bulb has been kept intact. Preserve the cranial nerve. So you see the cranial nerves going behind this structure here. And when that's followed into the dura, just incising the dura here would then show you the continuity of these nerves from the brainstem right into the infratemporal fossa. I'll be dealing with all these approaches in detail, but this is just an overview of what I'm going to be talking to you about in the next 1 hour. So as I told you, adding a subtemporal craniotomy and pulling the head of the mandible forwards would give you that exposure to get into this area. Now, this is the vertical petrous carotid, the geno-horizontal petrous carotid. This is the paraclival carotid, sphenoid sinus, antichondral clinoid process, supraorbital fissure. All these areas can be accessed by doing this craniotomy, adding it to the trans-temporal approach that you've chosen. So trans-temporal approaches can be taken anteriorly, taken posteriorly, and also inferiorly. So let's begin with what is one of the most important approaches in lateral skull base, one of the important trans-temporal approaches in lateral skull base, a very versatile approach, that is the trans-labyrinthine approach. So the I'll go step by step, beginning with the incision and then going deeper down. The trans-labyrinthine approach was first described by William House from the House-Ear Institute, and it's now a standard accepted approach for most large tumors of the CP angle. The trans-labyrinthine, the larger the I personally feel that the trans-labyrinthine approach is an ideal approach to deal with large tumors of the cerebellum. The larger the tumor, the better it is to apply a trans-labyrinthine approach, and I'll tell you why. Now you see this incision. There have been several modifications done to the trans-labyrinthine approach, mostly by my boss, my teacher, my mentor, Professor Mario Sanna, because he's got a very large series of surgeries done for acoustic neuromas, vestibular schwannomas. It's got more than the series at the Gruppo in Italy stands at around 3,200 or 3,300. So that's a very vast experience. And over a period of time, a period of about 3 decades, a lot of refinements have been proposed and achieved over and above the traditional trans-labyrinthine approach described by Professor William House. This begins from the incision. So the incision itself is fairly broad-based, wider than the traditional trans-labyrinthine approach. It involves taking an upper cut 2 finger breadths above the ear, a posterior cut 3 finger breadths behind the ear, and an inferior cut which stops at the mastoid tip. So once the skin incision is made, the flaps are elevated in a subcutaneous plane. So the first upper flap is elevated in a subcutaneous plane. And just a minute, I need to just make sure that the presentation in is not on an automatic mode. I don't know why this is running.
No problem.
Give me a minute. I'll just sort that out. Yes.
Okay. In the meanwhile, let me introduce people that came while you were talking. Hello, Vinod.
Hi, John.
Welcome,
Hi.
Vinod. Vinod's an ENT doc from Kerala, correct?
Yeah, I know Sampath. We know each other.
Hi, Vinod. How are you?
Hi, Sampath. Nice meeting you.
Nice meeting you too. Give me a minute. I'm having a problem.
No problem.
Okay.
Okay. Let me introduce some other people while we're getting things set up. AB, could you please introduce yourself? We didn't hear you the last time. AB, can you hear me? Okay. Go ahead. Try. Your audio is not working. I don't know what's going on. I don't know. Sorry about that. AB is a neurosurgeon from Indonesia.
Hi, AB.
Okay. Sorry, we can't get the audio there working. We'll get better.
Okay, I'm good to go.
Okay, go ahead. Take it away.
Okay, so okay. Is the slide visible? Okay.
Yes, excellent.
Okay, perfect. Okay, so so this is how we elevate the skin flaps, and I prefer elevation of the skin flap in a subcutaneous plane. So we have a thicker a layer down beneath, which would hold well when sutured tightly against a CSF leak. So you can see here that the skin incision is made in a subcutaneous plane. So we have the temporoparietal fascia and the musculoperiosteal layer together in one block. A T incision is made. The horizontal limb of which goes all the way towards the skin incision posteriorly, and a vertical limb leaving a centimeter and a half or a couple of centimeters from the anterior margin, which goes all the way down to the mastoid tip. Once the skin flaps are elevated, we prefer suturing the flaps to the skin using silk sutures, so then we don't need to use any retractors to hold any of these flaps in place. So the lesser number of retractors around, the better it is for you. You would also notice that we use what we call fish hooks or plastic. These are not really plastic. There's a silicone hooks which again minimize space occupied by retractor if one were to be used otherwise. So once the skin flaps are elevated and tied around, you get this kind of exposure. The temporal bone is widely exposed. The posterior exposure goes all the way up to the digastric muscle. One would obviously encounter the emissary vein, which needs to be closed, either using a large burr, or if it's a fairly large emissary, one would need to plug it with some bone wax. So once the temporal bone is widely exposed, you begin the drilling. Drilling is again wide-based. This is a departure from the traditional translabyrinthine approach, which dealt with a fairly smaller craniotomy around this area. But now we go much more superior, much more posterior. The craniotomy in the traditional translabyrinthine approach, as described by William House, would probably not involve the posterior fossa dura posterior to the sigmoid sinus, but now we routinely go posterior to the sigmoid sinus, go along the sinodural angle, middle fossa dura, and this is the kind of craniotomy we do for almost all the translabyrinthine approaches for all types of tumor. This is fairly standard now for in our translabyrinthine approach. So once the middle fossa dural plates, the sigmoid sinus, and the pre and post sigmoid dura are isolated, mastoidectomy is commenced. The posterior canal wall is preserved in this case. The mastoid tip is excentrated. The digastric ridge, which is a very important landmark in mastoid surgeries, is then identified. One could go up to the digastric muscle. For some of those who are not familiar with this anatomy, the best way I suggest to to identify the digastric ridge is to actually drill the whole bone around this area, and you'll actually see the muscle. There's no harm in exposing the muscle. It could bleed a little bit superficially, but you could always coagulate it using a bipolar cautery. So once the digastric muscle is exposed, or the digastric ridge is identified, you must then know that the facial nerve lies just a millimeter or two below the digastric, or medial to the digastric ridge. From that point, one could draw a line to the midpoint of the lateral semicircular canal. This is the arch of the lateral semicircular canal. This is another very important landmark in mastoid surgery. So once the posterior canal wall is identified, thinned out, mastoid cells are concentrated, the next structure one would identify is the incus, the short process of the incus. So the adductus to the incus, that is the opening of the largest cell of among the mastoid cells. Once that is expanded and drilled out, the first structure that's identified is the short process of the incus. So the incus is identified, the media is beginning to open up. The lateral semicircular canal stands out as a nice bulge at the floor of the adductus that's drilled out, or the antrum that's drilled out. And now that you've identified the digastric ridge, all you need to do is draw a straight line from a point that's maybe about a millimeter or two below or medial to the digastric ridge, to the midpoint of this arch here. You see this arch? So you take a line along this point and draw a line, and that's where you're most likely to see the facial nerve. And then one needs to go a little deeper and remove all the air cells around the facial nerve, the several air cells around this area. One needs to bravely drill around this area till you see the shadow of the facial nerve actually coming through. And this is the mastoid segment of the facial nerve. So the mastoid segment of the facial nerve is here. This takes a turn just under the lateral semicircular canal, continues as the tympanic segment of the facial nerve. Then it takes a turn again, and then continues down as the labyrinthine segment of the facial nerve. Then finally, getting into the fundus of the internal aortic meatus to continue as the internal aortic meatus segment of the facial nerve. So that's the facial nerve, the course of the facial nerve that you would encounter in translabyrinthine approach. Here you can see the shadow of what is the chorda tympani. Not really very important. Yes, unless you're doing a simultaneous ipsilateral cochlear implantation along with an acoustic neuroma, and I'll talk about it later. But otherwise, you could probably ignore this landmark, which appears again just lateral to the facial nerve on the posterior canal wall. But now let's go back to drilling the mastoid. The facial nerve being identified, we go posterior, retrofacial, to identify the jugular bulb and the dome of the jugular bulb. So the facial nerve, it's always wise to have a facial nerve monitor. And I would be very uncomfortable doing a surgery without a facial nerve monitor. I think that's a mandatory tool, and you could use it at every point that you where you encounter the facial nerve. So, but the mastoid segment of the facial nerve is fairly is something that is quite easily accessible, easily visible, and I don't think you really need to use a facial nerve monitor to identify this segment of the facial nerve. But deeper down, yes, I think the facial nerve probe and the monitor becomes very useful in identifying the facial nerve in the CP angle, especially when it's a large tumor and the facial nerve is splayed over the tumor. And sometimes it becomes very difficult to identify the nerve from the arachnoid. So that's when the facial nerve monitor is most useful. So, so once the facial nerve is identified, you go ahead and decompress the middle fossa dural plate completely, and the sigmoid sinus, the retrosigmoid posterocranial fossa, and the presigmoid posterocranial fossa. So this way, you would release the dura completely, you know, from all and it makes it so easy and comfortable to push the sigmoid down. If there is any amount of bone laterally in this area, So it becomes very difficult to release the sigmoid. The sigmoid would still be tethered to the bone that's present laterally. So the more you drill posterior or lateral and superior, the more this whole posterior fossa dura, middle fossa dura sigmoid complex can be pushed down with your instrument as you go deeper down into the cerebellopontine angle. I always say that if you want to go deeper, your craniotomy has to be wider, and this is true for all trans-temporal approaches. So now we have decompressed the posterior fossa dura, pre-sigmoid and post-sigmoid, the middle fossa dura and the sigmoid sinus itself. And this is best done with a large diamond burr, a 6 mm or a 7 mm diamond burr, which is very safe on a fine diamond burr, which is very safe on these structures. So now we're beginning to see the lateral semicircular canal and the posterior semicircular canal. So this is the labyrinthine block that has to be drilled through, and that's how this this approach gets its name, the trans-labyrinthine approach, because we drill through the labyrinthine block. Deeper down here is the jugular bulb. This is the trabecular bone of the occipital bone. And it's not really necessary to go into these areas. These areas often bleed, and it's definitely not wise to follow the bleeding deeper down, because then you're losing your track and you're going into the occipital condyle area. So this generally doesn't come into play in a trans-labyrinthine approach. You need to go to the bulb and the lateral wall of the bulb and superior to it. So now you separate the dura from the labyrinthine block. The semicircular canals are coming into view. There you see the jugular bulb coming to view. Again, best drilled using the largest size burr possible to be pushed into this area. So that's how you work safely on the jugular bulb. You see the shadow of the jugular bulb coming into view. That's the jugular bulb, and then you start, once this area is fairly well exposed, you start you proceed with the labyrinthectomy. Labyrinthectomy is best begun by drilling out the lateral semicircular canal. You see the ampullary end of the lateral semicircular canal, the non-ampullary end of the lateral semicircular canal. You go forward and then identify the posterior semicircular canal. The posterior semicircular canal too has an ampullary end and a non-ampullary end. The non-ampullary end of the posterior semicircular canal fuses with the non-ampullary end of the superior semicircular canal, which is often very close to the dura, and one has to do this skillfully, not to puncture the dura as you drill through the superior semicircular canal. But I was telling you that the superior semicircular canal also has an ampullary end and a non-ampullary end. The non-ampullary end of the superior semicircular canal fuses with the non-ampullary end of the posterior semicircular canal to form what is called the common crus. So the lateral semicircular canal has an ampullary end that's here. The superior canal has an ampullary end that's here. The posterior canal has an ampullary end that's here. You see the relationship of the posterior canal ampullary end to the facial nerve. It's just under the facial nerve, just medial to the facial nerve. So again, if you've not really skeletonized the facial nerve to the maximum, to as close as you can to the facial nerve, you could now do it. Now that you have the landmarks of the canals, you could now go confidently quite closer to the facial nerve. It's very important to skeletonize the facial nerve very well, because even a millimeter of bone on the facial nerve here could cast a significant shadow into deeper areas of your dissection. So I prefer going very close to the nerve, and it's so very easy once you open up the canal. You see, you open the posterior semicircular canal, this is the ampullary end, and you know that the facial nerve is just a couple of millimeters medial to the posterior ampullary end. Similarly, you know that the facial canal is a couple of millimeters again inframedial to the lateral semicircular canal. So you can be a little more brave on your facial once you identify the three semicircular canal. Here you see that the superior semicircular canal too has been drilled out. And then you go deeper, start merging all the ampullary and the non-ampullary ends. So the posterior ampullary end, preserving the ampullary ends are always important for two reasons. One is, it's always for one singular reason, that is to identify the facial nerve in its various segments. So as I told you, the ampullary end of the posterior canal corresponds to the mastoid segment and the genu. The ampullary end of the lateral canal again corresponds to the genu and the tympanic segments. And the ampullary end of the superior canal is useful later on as you trace the facial nerve in the fundus of the internal artery meatus. So just keep this in mind. We'll come to this later. The non-ampullary ends are not too significant, but then I would suggest, especially for the beginners, to preserve the ampullary ends as much as possible till as late as possible into the procedure. So now that you've opened up all the ampullary and non-ampullary ends, they all lead into what is called the vestibule. So the vestibule is a wide collection point of all the ampullary and the non-ampullary ends. You see again that the posterior ampullary end goes quite deep. So you saw the turn that it took a little previously. You saw that it was here like this. So this was what you thought was the ampullary end, but it was not really the ampullary end, but the ampullary end is further down. You see it goes further down here and takes a deep curve. Takes a deep curve. And there it goes. So this is the ampullary end. That was just the arch. And then it goes into the vestibule. This is the true ampullary end of the posterior semicircular canal. The lateral canal has been completely drilled out, and you see the vestibule here. The ampullary end of the superior canal has been preserved. Posterior canal has been preserved. This is the arch of the superior canal. Now you're beginning to see what is the endolymphatic tacna. This is the only thing what's tethering the presigmoid dura, the sigmoid sinus and the presigmoid dura to the bone here. So this needs to be cut. You see this is what is the utricular and the saccular divisions of the endolymphatic duct, which form the endolymphatic duct, and this is the endolymphatic sac. The endolymphatic duct is nicely seen. All this will be destroyed. Again, you see how closely we have decompressed or skeletonized the sigmoid sinus. It's not really necessary to decompress. What I mean is you don't need to expose the nerve, and you shouldn't be exposing the nerve, but you need to keep a very thin piece of bone on the nerve, but go as close as possible to the nerve. So this is how one would ideally do a skeletonization of the facial nerve in the mastoid segment and the genu of the facial nerve. So now the endolymphatic duct leads to the endolymphatic sac, which is present just anterior to the sigmoid sinus in the presigmoid dura. The sac is significant in sac decompression surgeries for Meniere's disease, and a lot of otologists would be familiar, or ENT surgeons would be familiar with the importance of the endolymphatic sac. But at the moment, you just need to run through this, cut the endolymphatic duct, push the sac down, and now you see that the sigmoid sinus can be nicely pushed down, decompressed. And this is important. So that's the reason why you need to remove. The more bone you remove around the sigmoid, the better it is for you later on, because you're able to push the sigmoid down with your instruments. With both, you have instruments with both your hands. Your left hand would have the suction, the right hand would have the drill. So with both these things, with the weight of these instruments, you just push the sigmoid sinus down, and also the middle fossa dura. Sometimes when you're doing your instrumentation from above, all these areas you're able to push them only because there is no bony rim around. So that's been taken off, and your instrument is predominantly on the dura or the sigmoid. So if there was that bony rim, that would restrict your movement. So your instrumentation, both on your left hand and right hand, would be more perpendicular rather than in a V shape. So the more perpendicular it is, the more you obstruct yourself with the instrument. That's the reason why you need to do this wide craniotomy, to make sure that the dura falls back. So you're going deeper down, and it's not really advisable to do this with the bone nibbler, but this is a dissection specimen, and ideally one would like to drill through this using a cutting burr. It's quite safe to use a cutting burr in these areas, especially when you've retracted the dura off the bone. And it's also important to use a cutting burr to save time, because the bony labyrinth is a fairly hard, thick piece of bone. You'll spend ages drilling this with the diamond burr if you choose to use that one. But this whole block above the jugular bulb, right up to the middle fossa dura, is best dealt with using a cutting burr. But as you go closer to any of the important structures, always use the diamond burr. So you see this is the jugular bulb, and when you're working over the jugular bulb, it's always better to go back to the diamond burr. Now, what you've seen here in this picture is bony removal between the jugular bulb and the intellonotomy meatus. The intellonotomy meatus is now coming into view, and it's identified by the dura that's present over the intellonotomy meatus. In the middle fossa here, the intellonotomy meatus. Remember that the intellonotomy meatus can be identified in an arch going from the base of the vestibule. So another important aspect of this vestibule is at the roof of the vestibule there is the facial nerve, and the floor of the vestibule also there is the facial nerve along with the other nerves. So the vestibule needs to be dealt with carefully. Don't go through the vestibule. You don't need to drill into these areas. You don't need to drill superior to the vestibule. Yes, you need to drill inferior, but we'll come to that later. And we do that in a much more controlled fashion. Now what's being done is elimination of bone between the bulb and the intellonotomy meatus. And it's very important to get to this area first before you do anything else, before you open the canal, before you go between the canal and the middle fossa dura, because one would encounter what is called the cochlear aqueduct. The cochlear aqueduct is a duct that comes from the basal turn of the cochlea and goes into the to lie along the medial wall of the jugular bulb, and it opens into the CP angle. Now, the relevance of identifying this structure is that once you identify the structure and open the cochlear aqueduct, you would release CSF. And all of you know, being skull-based surgeons, being surgeons interested in skull-based surgery, you would know that releasing the CSF is of utmost importance. The earlier you do it, the better it is for you, whether it is in a retrosigmoid approach or whether it is in a translabyrinthine approach. So you see that when you're doing a translabyrinthine approach, you really don't have access to the cistern, and it's practically impossible. And you'll have to do all your bony work with a quite a taut or a tense dura. So the earlier you get to this cochlear aqueduct, open it and release CSF, the better it is for you. Once the cochlear aqueduct is open, the dura falls back and you have more space to do your work. Here you see that the intellonotory canal has been nicely skeletonized. We have drilled all around the intellonotory canal, superior to the intellonotory canal, between the IAC and the middle fossa dura, and between the IAC and the jugular bulb. So this exposure around the canal determines your axis and your exposure in the cerebellopontine angle. I told you there are two things that make the translabyrinthine approach bigger, wider, better. One is the lateral bone removal, and now this step here, the drilling around the intellonotomy meatus. Now, as you drill around the intellonotomy meatus, there are two types of extensions, what we call the transapical extension. So the traditional translabyrinthine approach limited the drilling to the level of the intellonotomy meatus. So it was 180 degree flush with the intellonotomy meatus. But now we go all around and deeper, both inferior and superior to the intellonotomy meatus, because the deeper you go, you see this bony margin here. This bony margin gets pushed back as you go deeper, as you drill around the intellonotomy meatus. And we often go 320 degrees most of the time, sometimes even 360 degrees, skeletonizing it all around. Because the more you push this border that you see here medially or anteriorly, the more you get access to the anterior border of the tumor sitting around this canal. We're talking about vestibular schwannomas or also, Porsche-Peters phase meningiomas or whatever it is. So the more you push this, if there is bone flush to the intellonotomy meatus, you are blind to almost half the tumor. Yes, you can decompress it, debulk it, and get the anterior or the medial borders forward and then remove it, but it's always better to spend some time, go around the canal deeply, push the bone anteriorly, and release the bone to make sure. So this is what I mean by a transapical extension. So this was the traditional approach. This is what is done in almost all translabyrinthine approaches. That is what we call the enlarged translabyrinthine approach. We go up to about 270 degrees. 320 is type 1 transapical extension. 360 degree is type 2 transapical extensions around the internal artery. Okay. So once we have done the transapical extension, the next step would obviously be to identify the dura and the facial nerve. So the bone is carefully drilled out. So this is a very delicate step. One needs to be very careful not to let the burr tip jump at this point. You know, I've organized several workshops, and you know, I've seen several students working around the nerve, and you know, a small slip here could be catastrophic. You know, it could take all the 4 nerves down with your drill. So it's very important to be very carefully to carefully drill the dura of the internal meatus, and once you've achieved that, you go ahead and do what is one of the most fundamental and significant steps of the translabyrinthine approach. One of the reasons why the translabyrinthine approach scores over other approaches, despite the fact that it's quite a laborious process of having to know the anatomy, drilling the bone, and going, you know, spending a couple of hours to drill the bone. Of course, you'll get better as you do more cases, and that time can be cut short. But yes, when compared to, say, a retrosigmoid approach for acoustic neuroma, this is a longer, more tedious approach. And one needs, again, one needs to know the anatomy of several structures to reach this point. But the beauty of it and the benefit of having to go through this laborious process is that you get to see the facial nerve right in the beginning. And the facial nerve is very safe unless, you know, you have lost a moment of your concentration. So how do you identify the facial nerve? You see the facial nerve even before you see the tumor, and that's very important. So in a largish tumor with no hearing, the translabyrinthine approach becomes a very, very valid option. I'll tell you how you find the facial nerve before you see the tumor. You've not opened the dura of the internal meatus. So right now you're at the fundus of the internal meatus. This picture shows the vestibule, the genuine of the facial nerve. You don't need to see the tympanic segment, the labyrinthine segment. They're hidden inside this piece of bone, which is all inside the middle ear complex. So we don't really. So what we're concerned is the exit point of the facial nerve, or the transition between the labyrinthine segment and the IAC portion of the facial nerve. So how do you do it? Now this is the vestibule, and I told you that one needs to identify and keep and preserve and know the ampullary end of the superior semicircular canal. The other canals have been taken off. Now we would need to identify the ampullary end of the superior semicircular canal, because this is where the superior ampullary nerve, which is a very thin but very important nerve, arises from the ampullary end of the superior semicircular canal and comes to lie in a small canal for itself. It's called the ampullary nerve canal. So this ampullary nerve has to be identified and plucked out. You see, high up, the facial nerve is somewhere here. I'll come to that later. So we're in another tangent, another direction. The superior ampullary nerve is identified far laterally, brought down, and that continues as the superior vestibular nerve. So you see now, the superior ampullary canal was here. We brought down the superior ampullary nerve, and that continues the superior vestibular nerve. So superior vestibular nerve is brought down, and then you see the facial nerve behind. The facial nerve is coming from another direction entirely. It's coming from here, it goes down. I call this a waterfall sign. You know, it's like, you know, it's like a cascade. It's nicely seen. You'll never go wrong if you begin from here. If you start fiddling around the nerves at this point, there is a distinct danger that you would pluck the facial nerve itself. Okay, so when you begin from here, there's no such danger. Now this point here is what is famously called the Bill's bar, identified first by Bill House and then taken up by many as a very important landmark for the facial nerve. The earlier technique as proposed by Bill House himself was to first identify the facial nerve, identify the Bill's bar, identify the facial nerve, and then go anteriorly or laterally and pluck the superior vestibular nerve out. We now don't do that. We leave the Bill's bar. We don't even drill this area. So we leave the facial nerve in its position, come from this point superiorly and superior vestibular nerve. Superior vestibular nerve is taken down, inferior is inferior vestibular nerve. This is what is called the horizontal crest. It's what you have drilled or left behind. So this needs to be flush with the vestibule for you to clearly see the inferior vestibular nerve. Now, you need to take this out. This is not the right, this is too long. This crest is exaggerated. This needs to be brought down or closer to the inferior edge of the vestibule. So once you've done that, you see the origin of the cochlear nerve as well. Now, behind this is the cochlear nerve. The facial nerve is here. The cochlear nerve is here. The superior vestibular nerve, inferior vestibular nerve have been taken down, and this is where the tumor starts to appear. So now you've identified the facial nerve and the cochlear nerve much before you've identified the tumor itself. Take it down and incise the dura, taking care not to damage the suprapetrosal sinus. Remove the dura. I excise the dura completely. You see the facial nerve. This is where the tumor would sit, but then you know where the facial is. You have the facial nerve probe. One could then slowly start from the posterior border. Once the dura is exposed, you will see the posterior border of the tumor first, and you could possibly see the cerebellum. Another big advantage of the translabyrinthine approach over other approaches is the fact that there is no brain retraction. Cerebellum, middle fossa, dura, middle fossa. So no brain retraction whatsoever. The tumor will be right here in this space that you're exposed, and you'll first see the tumor, and you'll hardly get to see the cerebellum throughout your dissection. Unless it's a very tense tumor, very big tumor, and you fail to release the CSF from the cochlear aqueduct. If that doesn't happen, sometimes the cerebellum may pop out, but then once you open the cistern, that goes back again, and you're back into seeing the tumor sitting like what we call a laddu. A laddu is a sweet that is quite popular in India, especially in South India. So it's like a nice round ball which is sitting in front of you to be taken out, and the facial is already identified, and you can do your dissection very well. So deeper down, now again, what's the significance of the transapical extension can be appreciated here. Now you see that having done a wide or a deep transapical extension, having drilled out all this bone, this is the jugular tubercle, by the way. Having drilled this bone out, one can see the prepontine cistern very clearly. The pons is seen here, the Doralus canal, the sixth cranial, the clivus has been reached. So that's the medial limit. The lower cranial nerves are seen coming here between the jugular bulb and the tubercle, the 9th, 10th, 11th cranial nerve. The choroid plexus is seen here. The ica is seen looping around the facial. The cochlear nerve has been taken down. It's not always necessary to sacrifice the cochlear nerve. The cochlear nerve can be preserved, and hearing can be restored or restituted by doing what is called a simultaneous ipsilateral cochlear implantation in this case, but provided you have managed to preserve the cochlear nerve. So the cochlear and the facial nerve have been preserved, then all is not lost as far as hearing is concerned in a translabyrinthine approach, because one could do a cochlear implantation to restore hearing. So yes, this is a hearing destructive procedure, but at times in a smaller tumor where you're able to preserve the cochlear nerve, you could restore hearing. Now you see these small branches. It's very important to preserve these branches. These are what we call the labyrinthine and the cochlear arteries. If there is a branch from the ica that goes into this area, always preserve it. Now, a lot of retrosigmoid approaches don't end up preserving hearing. It's retrosigmoid approaches are hearing preservation surgeries, but a lot of them do not preserve hearing because of the fact that many surgeons do not appreciate the importance of these small arteries that come off the ica and supply the cochlea and the vestibule. The vestibule obviously is taken out. The cochlear artery is important because if the artery to the cochlea is damaged, if that's taken out during dissection, over a period of time, the cochlea can ossify. So the advantage of hearing preservation is then only temporary. It could last a few months or a year or a couple of years, but then once the ossification sets in, the hearing is lost. So as all of you would know, the structures in this area. So there is this vein in front of this choroid plexus. I don't know what's the name of this vein. I hope sometime at the end of this discussion, one of you could tell me the name of this particular vein. But lower down we have the pica, the pica vein also. So there is this one vein just anterior to the choroid plexus that I don't know the name of. So if one of you could tell me, I'll be very happy. So yes, so you see the extent of exposure. You turn the microscope down, you see all the lower cranial nerves, the 9th, 10th, 11th cranial nerve, jugular tubercle. You see how wide. You see, you turn the microscope above, you see the trigeminal nerve, the Dandy's vein, the superior cerebellar artery, the PCA is here, and trochlear nerve can all be seen by a little bit of gentle retraction. Sometimes the trigeminal nerve can be seen even without any retraction, the tentorium. So this is, according to me, a very wide approach to the cerebellopontine angle. The advantage are many folds, and I think this should be seriously considered as an effective option for large vestibular schwannomas where the hearing is lost. Now, closure is done. We obviously do not want a CSF rhinoria. So this whole big cavity is now, and it needs to be isolated from the midlear cavity and thereby from the eustachian tube. So we remove the incus, we put in a lot of perichondrium, we pack the perichondrium, the cavity with perichondrium, and make sure that this cavity is sealed from the midlia that lies anteriorly. You see this? The incus is removed, and the malleus is preserved. It's very important not to damage the tympanic membrane, but this area, the epitympanum and the area of the eustachian tube, should then be closed with periosteum. Now, that's about the classic translabyrinthine approach. So I could probably take a break here and take some questions, or go ahead and describe what is called the transaortic approach, where we bring down the posterior canal wall. There are a few slides here, or maybe John, what I'll do is I'll go through a few more slides and then probably take a break and go to describe the other trans-temporal approaches. So I guess I'll finish the extensions of the translabyrinthine approach. So I would finish that in about 5-7 slides, and then I'll take a short break.
Okay, that sounds good. Sounds good.
Okay? So
sounds
yes.
Good.
So why would you need to go anteriorly now? Now we've finished the translabyrinthine approach. So we've described, I've shown you all the steps. So why would we need to go anteriorly? Now there could be these huge tumors, that go right up to the midline, or spinopetroclival meningiomas, or large lesions where you need to get up to the clivus. So when you do that, the transapical extension here that you've drilled would not be enough. You see the shadow. So this it would still be quite a dark area, as the medialmost parts of the tumor could be beyond your reach. So then the next step to get that additional exposure, to go more medially along the posterior petrous face, would be to bring down the canal wall. So the posterior canal wall, which you had so diligently preserved, needs to be brought down. Now, before doing that, once you bring down the canal wall, you are now exposing the cavity posteriorly to the external ear canal. So you just can't bring down the canal wall. You need to do what is called the blind sac closure of the external aortic canal before you bring down the canal wall. Because lining this posterior canal wall anteriorly is a very thin skin, the ear canal skin, that's very thin. So that needs to be sutured. So what we do is a blind sac closure of the external aortic canal. So we do a nice transection of the external aortic canal. Now we're getting into the external ear canal. You transect it nicely, and separate the skin. Now this is very important. This is a topic by itself, how to do a perfect blind sac closure. Most trans-temporal approaches require very perfectly done blind sac closure. This is generally done in 2 layers. So if you do not know how to do a blind sac closure, please learn that first before you attempt any of these trans-temporal approaches. Because if you don't do that, you'll end up in serious problems. Not now, but later on. In 6 months down the line, especially if you have a patient who is not followed up well, some of these blind sac closures may give way, and then you're exposed with a fistula from the external ear canal down into the CP angle. This not only exposes a very crucial, intracranial cavity to the external environment, but also the canal skin can migrate medially into the cavity to form what is called an iatrogenic cholesteatoma. So you don't want any of these things to be happening. So you need to do a perfect blind sac closure. How is it done? The first step is to do is to separate the skin from the cartilage. Once you separate the skin from the cartilage, you turn it inside out and suture the skin separately from the cartilage. And then you go back and suture the cartilage to the soft tissue, or if in a fairly elderly patient, you get cartilage on both the sides, so you suture the cartilages to themselves. So this way there's a scaffolding layer beneath, and the skin that you've sutured from inside out or from outside in is turned outwards. So the edges of the skin is not directed inwards, but it's directed outwards. So there's no real chance. And then you have to make sure that there is no hole here. There is no perforation of the external aortic canal skin all around this suture line. So once this is closed, you inspect the skin all around the external aortic canal and then do a second layer closure. And by this way, you have achieved a perfect blind sac closure. Once the blind sac closure is done, you go ahead and bring down the canal wall. Working on the facial nerve. The facial nerve is completely exposed. This is the area of the stylomastoid foramen. It's again very important to make sure that you don't, it's important to strike the right balance between a well skeletonized facial nerve and a very narrow or a very thin canal, a bridge. Because this facial nerve canal, what we call the fallopian canal, if it's too thin, you would later on be manipulating your instruments anterior and posterior to the facial nerve as well. So when one of your heavy instruments, let's say the drill is on the facial nerve and you're doing something from above, you could tend to fracture the facial nerve. So the balance between a well skeletonized facial nerve and reasonably sturdy fallopian canal has, and that's very crucial when you're doing this step. So you bring down the canal wall, isolate the facial nerve. This is the mastoid segment, geno-horizontal portion. This is the tympanic segment, the labyrinthine segment somewhere beyond, not really important at this point of time, but you bring down. So by doing this, you see the amount of light here in this area. You see the amount of light that's now shed into the deeper areas, into the transapical extension. So that's what you've removed that shadow which was cast by the posterior canal into these deeper areas. Now we can do further drilling right up to the clivus under direct vision and under direct illumination. So that's the advantage of bringing the canal wall down. Obviously, we'll take out all the media structures. These are useless now. In fact, it's very important to carefully take out the canal wall skin tympanic membrane, because this epithelium would lead to formation of cholesteatoma. So that's again another fundamental step. You need to not only make sure that the blind sac closure is well done, but it's also important to close to eliminate all epithelium, including the tympanic membrane canal, the medial canal wall skin. All that has to be taken out to achieve something like this. Now you see the mastoid segment, geno-horizontal portion, the geniculate ganglion, the labyrinthine portion which was hidden, but you don't really need to work in this area. This is just for an anatomy, just to show all the segments of the facial nerve right up to the brainstem. So you see the stylomastoid foramen, mastoid segment, geno, the tympanic segment, ganglion, the short labyrinthine segment, that's the shortest segment of the facial nerve, and the fundus, the IAC portion of the internal aortic meatus, and the porus of the internal aortic meatus, and the CP angle segment of the facial nerve down right up to the root entry zone. The ICA is here, the cochlear nerve is still preserved, the cochlea is preserved, You see the shadow of the petrous ica into carotid artery coming into view. Eustachian tube is also seen, and this is the advantage. So you can manipulate your instruments. So now we have removed all this bone. The hypotympanic bone has been drilled out. The cochlea is still preserved. So you can still go ahead and do a cochlear implantation in this case. So you see how you can work on either side, anterior and posterior to the facial nerve. With this approach, you can see the inferior sinus climbing along the clivus. You can see the basilar artery. You can see the basilar artery nevertheless by tilting the microscope even without this extension. But yes, with the transaortic approach, one could really get a beautiful representation or view of the prepontine system, the basilar artery, the ica, the sixth cranial nerve, facial nerve. So you see the illumination is much better, the exposure is much better, and yes, so you can see all the structures like I've shown you before. Everything else is the same except the fact that this anterior extension or anterior so with this posterior petrous face meningioma can be completely removed under direct vision, complete exposure of the cerebellopontine angle. And again, I emphasize, do you see the brain? The middle fossa dura is covering the temporal lobe. Barely any retraction of the cerebellum. So this is the distinct advantage of the translabyrinthine approach. Okay, so the vertebral arteries are here. The pica is seen coming out of the vertebral artery. The 12th cranial nerve can also be seen now. The choroid plexus is seen. This is where you put what is called an auditory brainstem implantation quite commonly done in neurofibromatosis 2. So where hearing is completely lost, where there is bilateral hearing loss. So this is the foramen of Luschka identified by the choroid plexus. So one would put the implant, the electrodes of the implant into this small foramen. So that's also seen very clearly. And that's the lower cranial nerve, 9th, 10th, the 11th with multiple rootlets, the 12th cranial nerve. So, and then the superior extensions, the Tandy's vein, everything is perfectly seen. Whatever needs to be seen is seen, and the facial nerve is bang in the center of the field. And that's also, and you see the amount of space that you get between these structures. Closure is done by using fat to plug into the cavity. We don't really use dural patches, but what we do is we do a very, very tight, diligent closure of this. And that's why it's very important to raise the flaps properly in the first place. That's why I told you it's always nice to have a thinner skin flap here and a thicker lower flap, or the medial flap, because that's the one which really when sutured properly prevents the CSF from coming out. So when this is closed, of course there's fat beneath this. We secure fat with some amount of fibrin glue all around, and then do a perfect watertight closure of the second layer of the flap, and that takes care of any CSF leak problems. So the next approach would obviously be a transcochlear approach. I think I could use a break to give rest to my vocal cords for a couple of minutes before we go ahead into the next couple of approaches. Yes, John, so I'll be happy to take a break here, and I could take in a few questions if you wish.
Okay, excellent, Sampath. Before we open up, I'd like to say hi to Ipe. Ipe, leading a neurosurgeon's dream, going from the OR to a presentation.
Hi, great to see you. Thanks for setting this up. I hope this. Thank you so much. It's a pleasure and honor. As I told you before, it's great. It's a wonderful platform. I'm thoroughly impressed, and it's great to meet all of the participants here. Most of them are people whom I don't know. So, new batch of friends from there. Thanks, Ipe.
I think we're getting feedback, Ipe, from your system. So you need to turn one of the screens off, Ipe.
Okay, Sam, can you hear me?
Yes, it's better.
Okay. Now, the beauty of this thing is that we have almost 15,000 viewership in about a month.
Wow.
The presentation is viewed more than 15,000 times. That's what we've seen. I mean, it's been shared on Facebook, on every social media, and So these classes would we would want it to reach to the whole world, and now WFNS is taking notice of this. So AMSRS, the Super Sunday, and Neurosurgical TV is now being really seen. It's a very important thing. I remember when we started off with John, not maybe 1.5 years back. I remember. I realized what the potential was, and I asked John to go ahead. John is a workaholic, and so is Hira. Now I realize how neurosurgery is reaching now. MSRS is looking at medical students as well as residents, and the young neurosurgeons. These are the people who should change instead of trying to change older people. With all due respect to them, it's so. For example, if you talk about this approach for jugular foramen, I remember learning this and doing it while all the neurosurgeons would say, no, you shouldn't be doing it. And anyway, we've been together in many workshops, so we know each other. So the whole point is all the approaches has to be learned, and one has to be comfortable with a few approaches, whether it is endoscopic, whether it's lateral skull base or anterolateral. I mean, for example, I'm comfortable with anterolateral, so I try to take out things with anterolateral. Now, if I need to do a mastoidectomy, I can do a mastoidectomy, but I will never be as good as Sampath because it's Sampath's field. On the other hand, like endoscopic, Narayanan and Prabhakaran are very good. So one cannot cover everything. It's very important to also realize that one cannot cover everything. So let us do these classes for the young people. Let them realize what they need to. Let them select what they want to. And let them also learn everything. I mean, not just anterolateral or not just endoscopic or not just lateral. They should have a complete 360 view of anatomy, and that is when skull base is complete. So thanks, Sam. It's an honor to have you around. So
the honor is entirely mine. Absolutely bang on in whatever you said. I think yes, and the platform is wonderful. I mean, this is so professional, and congratulations to you and your team for having set this up, John. Great to know you, and I'm sure that this will go a long way. It's fantastic to be introduced to this platform. I'm really honored. Thank you so much.
Okay, let's open it up for discussion.
Questions?
Any comments or questions from the panelists?
Yeah, I mean, well, I'd like to make a comment. So, recently I was operating a tumor, a CP angle tumor in India. It's a giant tumor. What had been done was somebody had shunted this patient. So, I mean, it was a 6 centimeter tumor, and there was, we didn't notice that there was transforaminal herniation. So there was literally no cerebellomedullary cistern. So if you don't have a cerebellomedullary cistern, your schwannoma surgery stops then and there. Okay, then it's not surgery. It's massacre. So, well, that's exactly what I had to do. So I had a CUSA and I had to go at it. I could save the 7th for sure, but I had to leave some tumor behind. And the cerebellum, everything was so tense. We tried. There was literally no cistern. We went right down the cistern, and then I remembered maybe in this kind of a case, it's a huge tumor. I could have gone ahead and did a mastoidectomy and did this approach. So sometimes these kind of, I mean, usually I never have any trouble taking out a schwannoma through CP, I mean, through a retromastoid route. I've been doing it for 10 years. But then sometimes you get into these situations where you really need these alternate routes, and they are helpful. I mean, if I could at least decompress the tumor, then it would have been much more easy, and I could have gone back. I wouldn't have to take out the whole tumor through that route. I mean, maybe Sampath would have been able to do that, but if I did a simple mastoidectomy, I mean, translap, I would have been able to at least decompress that tumor and then get enough space so that I can go back to my retromastoid and then.
Correct. Absolutely, I completely agree. Yes. So yes, the anterior parts of the tumor, around the facial nerve. So a transmastoid approach would, in such a situation where it's 5 centimeters, 6 centimeters, when you do a transmastoid, you're on the head of the tumor, and then debulking becomes easy. So yes, I think that could have helped for sure. Yes, I'm sure it was a very challenging case. 6 centimeters I've rarely seen. It's one of those fantastic cases. I would have probably been. I would have loved to be next to you. Seeing you do this case. Wonderful.
Okay, Naru, do you have a question? Yeah, unmute there.
Hi.
Go ahead.
Hello. Thank you very much, Dr. Sampath Chandra, and good morning, Dr. Lipe Sherian.
Hi.
I have 2 questions. I have 2 questions for Mr. Sampath. I want to know what are the properties, what are the indications of this approach, and in this approach, what are the complications we have to avoid or we have to know after surgery, and how and what is your experience about this approach? Because in my department we don't use this approach. We are usually use retrosigmoid approach for tumors like neurinoma of vestibular, acoustic neurinoma. Sometimes we just use temporal approach, classical temporal approach, to remove all tumors of skull base. Like and we drill the pterion to access to the fissure, canal fissure. But this approach, I see that is very nice and very good, but I scare about complication, maybe CSF-like infection complication after surgery, like abscess, because we know that if our patient have maybe otitis and we perform this approach, maybe we can have abscess after surgery. And I want to know in your practice, please tell me what's the effective indication of this approach. Thank you.
Okay, so yes, so the first question I would like to answer is regarding the indication. So you see, coming from an ENT background, I would be more familiar with the anatomy of the temporal bone, and I wouldn't have any problems going through the temporal bone to reach the CP angle. Being a neurosurgeon, I'm sure you're more comfortable dealing with the brain tissue. Your handling of the brain tissue is much superior to probably an ENT surgeon. So, I'm sure somebody like me would probably try to avoid the brain as much as possible vis-a-vis a neurosurgeon. So I can understand the fact that in neurosurgery department, the preferred approach would be retrosigmoid approach, and in a ENT skull base unit, the preferred approach would be a translabyrinthine approach. But that's besides the point, because we could have our preferences, and we all are experts in our own domains. But there must be a technical evaluation as to what are the indications for each of these approaches. And the indications have to be weighed against the second part of your question, that is complications. Okay, so first thing, indication. So if you were to put some brass tacks, so what would be logically the indication of a translabyrinthine approach? A translabyrinthine approach would obviously mean destruction of hearing. So the first indication is a CP angle tumor where there is no hearing, where the hearing is non-serviceable. Again, there is a lot of, this is a topic by itself. What exactly is non-serviceable hearing is something that Again, there is a difference of opinion between ENT surgeons and neurosurgeons. So, but it's sufficient to say at this point of time that a bad hearing, let's say about 70-80 per decibels hearing loss with a bad ABR, you know, with a lot of latency. So this is one of the indications. Okay, and so to reach the CP angle. So in case of a larger tumor, I prefer the translabyrinthine approach because the hearing would anyway be gone. If it's a 3, 4, 5 centimeter tumor, the hearing would there would be no question of hearing in such tumors. Very rarely do you have preserved hearing in larger tumors. In a smaller tumor, and I would say a lot of 2 centimeter acoustics have good hearing. Anything up to the extent of a 2 centimeter tumor with a good hearing, I would prefer retrosigmoid approach. A middle fossa approach is the third approach that could be used to remove acoustic neuron. Remember, the middle fossa approach is generally reserved for intracranial tumors with good hearing. Now, what's happening is there's been a paradigm shift in the treatment of intracranial tumors. I'm sure most of skull-based surgeons, ENT, neurosurgeons tend to avoid operating on very small tumors, intracranial tumors, though it was a trend in the past. Yes, it has a logical explanation. You can go in and remove the tumor, but the risk to the facial nerve, the cochlear nerve, and also the vestibular nerves. But the vestibular nerves also become important you have to preserve all the 4 nerves, isn't it? So as much as, you know, so it is to remove a very small tumor and to put a few other important nerves at risk is not really acceptable unless you are very good at it. There are certain centers like, you know, the House Ear Institute, which has done one of the world's largest number of middle fossa. They're very comfortable doing a middle fossa. So they would go in and remove intracranial tumors as well using a middle fossa approach. And but I see that many centers, we have done a fair amount. Professor Mario Sanna's center has done a fair amount of middle fossa approaches. But I would say that in today's world, these tumors would go more into the wait and scan category. They would be waited and watched. And since the tumor volume is low, the growth of such tumors is also slower than compared to other tumors. Or some of these tumors would end up with radiosurgery, which I'm not a big fan of. But nevertheless, so that's a valid option as well. So radiosurgery or wait and scan. But yes, the middle fossa approach is for very limited intracranial tumors. But any of these tumors that dip down into the CP angle are again contraindications because it's always difficult to reach the posterior fossa from above in a very limited in the classical middle fossa. Of course, if you add the Kawasaki approach, you can do anything, but in a classical middle fossa, that's not really easy. But yes, translabyrinthine approach, bigger tumors, no hearing. I would do a retrosigmoid approach in smaller tumors, 2 centimeter tumors, probably even 2.5. If the hearing is good, go ahead and do a retrosigmoid. Coming on to complications, yes. So just because the craniotomy or the dural opening is bigger doesn't really mean that could get infected. Now, infection is not a significant problem in any of the translabyrinthine approaches. No, I have worked or seen many centers. I've been to many centers where translabyrinthine ENT centers, you know, which do a lot of translabyrinthine approaches, and the rates of CSF. We'll come to CSF leak rate, but the rate of meningitis, the rate of cerebral abscesses is practically at par with retrosigmoid approach. There's no significant difference. One needs to make sure, of course, there are important steps that one needs to learn, but when done properly, and most centers are serious centers which do this, and they do it properly. So when you plug the editors well, I told you a few important points as we were going through the translabyrinthine approach. You plug the editors well, if you make sure that the midlear cavity is well sealed from the posterior cavity, there won't be any CSF rhinorias, nor will there be any ascending infection. Now, just because the posterior cavity is larger, that doesn't mean that the skin goes over it. So there's no real worry about a meningitis. That's not my concern, but CSF leak, yes. CSF leak, now CSF leak looks like it will be, it could be the incidence of CSF leak could be higher with the translabyrinthine approach, considering the fact that it's a much bigger, cavity inside. That's not really true. In fact, in Mario's center, the CSF leaks are one of the lowest in the world. And again, this is a subject that, this depends entirely on the skill sets of a surgeon. How to minimize the CSF leak. I've seen few people doing translabyrinthine approaches where CSF leak is fairly a common occurrence. It happens practically with every case. But I've seen the same thing in my center where I was trained, Anna Mario's center, where CSF leak is, yes, you may have a small collection once in a way, subcutaneous collection, but again with a tight pressure, that's eliminated. I have practically in my 6.5 years, I've not seen a single case where we required a lumbar drain. Okay, so if there was a significant leak, a couple of times in a year, we would go in, open, and make sure that the leak is closed. But otherwise, CSF leak rates, if done properly, there are many smaller issues that, or I would say refinements in the translabyrinthine approach, which I have not completely discussed. How to pack the fat, what should be the length of the strips, and how it should sit in the hole, and especially because we don't use a dural patch, how the suturing has to be, how the flaps have to be made. All these issues, when dealt with properly, would give rise to very low CSF leak rates. And this is from my personal experience after having been trained from, I did 2 cases the last 3 weeks. Both of them, fortunately, did not have a CSF leak. So if done properly, CSF leak is not a problem. But yes, it all depends on how you deal with your closure. And that comes out of experience. But otherwise, I would say yes, CSF leak could possibly be more with the translabyrinthine approach because of the fact that we have a bigger, wider cavity when compared to a retrosigmoid approach, which is narrow. You get the dura back, you get to suture the dura back. Here we kind of move the dura. There is a hole without a dura to put back, and we close it with fat.
Okay, very good. I think Ulrich has a question. Go ahead, Ulrich.
Yes.
Yeah.
Thank you very much, Mr. Sampath. I understand what you're saying, and thank you for your explication. Thank you very much for your presentation.
Okay, Ulrich, go ahead, Ulrich. Go ahead, Ulrich.
Thank you very much.
Hi, Ulrich.
I'm having problems, Ulrich. You may have to write the question. Oh, go ahead. I'm sorry. Ulrich, try again, Ulrich.
I think that he want to know the position of the patient and the head during this approach.
So, the patient is flat on the table with head turned to the opposite side. That's it. It's a very simple position. Routine mastoid position where there is nothing fancy about it.
Well, I have one question to Itil, sir.
Go ahead.
Like, as we know, for like CPA tumors, we do transmastoid or translabyrinthine or some like retrosigmoid approach. But what I'm thinking, like, how often do you use or we use endoscopic approach for the CPA tumors? Can you get, sir?
Is that for IPE or for Santa?
For IPE, sir.
Okay. Oh, for IPE. Did you hear that question?
Like, how often do we use endoscopic approach for the CPA tumors?
Yeah. Well, purely endoscopic approach for CP angle?
Yeah.
Yeah, I've seen a lot of guys doing it, but then, you know,
what I know is like microscopic.
you have two screens open.
Yeah, okay. Okay. I generally, for the last 20 years, I've been seeing and doing with the microscope. So,
Exactly.
you know, the endoscope is a 2D thing. So, in the CP angle, you need a real 3D view because the facial nerve is on a different plane. Your tumor, I mean, your fifth nerve is on a different plane. Your lower cranial nerves are on a different plane. The vessels are on a different plane. The cerebellum is on a different plane. So I am used to the 3D that my microscope provides, and I know when in a tumor, I know exactly this facial nerve is going to be somewhere around here. So I wouldn't really put, I put the endoscope actually. Once for a few patients, we put the endoscope and I was not very comfortable. I mean, my friend Henry tells me, and my Roman Wozniak also tells me that it's very good to put in the endoscope and see for remnants. I've never felt the need for that actually. I mean, I don't, when I leave tumor, if I leave tumor, that's because I know about it. I mean, I know there's tumor left, but it's not because I can't see it. So I really haven't felt the need for it. I mean, so I don't think I'm going to be, well, now we're designing something like 3D endoscope, which will probably replace microscope in the next 10 years.
I was going through one paper of CT tumors, and what I found in Russia, like they use the endoscopic approach for the chasing of CP tumors.
Yeah, I mean, I know about what you're talking about, but my experience in this is nothing, literally nothing. I mean, endoscopic approach for CP angle tumor. Yeah, maybe for MVD, yes. I mean, I can, yeah, Sampath, please go ahead.
I think, see, endoscopic assisted microscopic surgery is different, and purely endoscopic approach, which is now being discussed in many forums and developed and proposed by a few centers, and I know this center. So this is another story. Now, I have written a letter to the editor, after one of the publications came up, describing this particular purely endoscopic approach to the CP angle. Now, this involves a few steps which, according to me, deserves a certain amount of criticism. Now, the thing is, when you're putting an endoscope through the ear to reach the CP angle, you have to first begin with a blind sac closure. So eventually, these are the standard steps of endoscopic. I've seen these approaches, I've reviewed literature. So the first step is to actually do a blind sac closure. So you're losing hearing. The second thing is to go through the cochlea. You drill the cochlea and go into to identify the internal meatus. Second. Third thing, to get additional exposure, which is so very limited, because you're going through the ear canal, you need to then drill the anterior canal wall, thereby kind of causing some amount of destability of the temporomandibular joint. So, and then you're going somewhere anterior, medial to the facial nerve in a very difficult tunnel to reach the internal meatus. So why would you do this? And at the end of this, the external, the internal canal segment that would be exposed after all this is very limited. It's not like you're having a big bowl where you're able to look into the CP angle. So and this has been proposed. The purely endoscopic approach has been proposed for intrameatal tumors. Now, intrameatal tumors, as I told, just referring to previously, have good hearing and nobody does anything about these tumors. Generally, they're left to grow. Yes, middle fossa approach is a valid option, but again, requires a little bit of training and other things. So, if it's an intrameatal tumor, a middle fossa approach always scores over a trans-canal and endoscopic approach because you preserve hearing. And in this case, you go ahead and intentionally destroy hearing in a tumor where the hearing is practically perfect, normal. Doesn't make sense to me. So the indication proposed is an intracanalicular tumor with giddiness, with severe intractable giddiness. Now, how many patients do we see like this? It's very rare. So at the moment, that approach I would say deserves criticism. At this, to put it mildly, doesn't make sense to me.
Yeah, I mean, Sampath, on Sunil, and if anybody gives me an intrameatal tumor, which I mean, I very, very rarely operated. I mean, maybe under 5 cases in my last 10 years or so.
Yep.
I would any day go with a middle fossa approach. I need a 2 into 2 centimeter craniotomy.
Correct.
And after I retract my dura of the middle fossa, I drill the entire meatus, and I can see the entire meatus, all the nerves clearly.
Yes.
And once I open the dura and I can take out the tumor, it's neat and clean. And I mean, it's not like these very aggressive things, you know. I mean,
yes.
Although it's called middle fossa approach, it involves peeling off the dura in the right plane, and if you do that properly, there's no bleeding at all.
Correct.
And once you do that, and once you drill I mean, you can easily find out where the aquate is, you can find out where the GS pain is, you're causing no hurt to anything. You drill that meatus, and then you open the dura.
Correct.
I mean, IAC dura, you're there.
Of course.
You really don't need all this. I mean, in 45 minutes, you're done. I mean,
yes, and you're preserving hearing.
You should come to one of these live surgery workshops, or maybe you should come to a cadaver workshop and you see these things, and then you realize that all these things are not necessary, you know.
Correct.
It's like people tell me I do trans-pterygoid approach to the CP angle. I mean, I really don't know. Yeah, I mean, you can do a trans-pterygoid, but I can open from lateral, so it's much more easy.
Correct. We have a question from a neurosurgical resident from Zimbabwe, home of your buddy Kazadi Ipe. Aaron Musara, he says, I heard you say there is a need to be careful down there, but you want to be effective as well. What is your usual preferred cutting burr size for this approach over the tympanic bone, which you said is a very tough, 2 millimeter or 1 millimeter?
Now, if the question was referred to me, and the question was the size of the burr on the tympanic bone, which has not really, we've not spoken about the tympanic. That's another approach. That's a part of the infratemporal fossa approach. But if that's what he wants to know, Mr. Aaron Musara, if that's what he wants to know, the tympanic bone has to be drilled through the ear canal. So the posterior canal wall has to be brought down. I would use a big cutting burr, maybe a 4 millimeter cutting burr, to bring down the canal. So that's the posterior part of the tympanic bone. The anterior part of the tympanic bone needs to be separated first from the parotid tissue and then drilled. Again, this I could be comfortable using a cutting burr, but for the beginners, you have to make sure that you don't lacerate the parotid capsule. So this has to be a little more carefully. But again, a 3 centimeter burr would be ideal till you reach the vertical petrous carotid canal. Once you're close to that area, and that's identified by the stitching tube itself, because the genu of the petrous portion is on the undersurface on the inferior to the stitching tube. So you're coming close to that area. From at that point, I would probably shift to a coarse diamond burr, the size of about, again, 3 mm. Again, bigger the better. It depends on the exposure. Suppose the tumor is along the infratemporal fossa, you need a wider exposure there. So I would take maybe even a 4 millimeter burr, but 3 mm I think would be ideal. And then when I'm really close, when I'm on the carotid, I would use a fine diamond burr.
Okay, go ahead, Manuel. You have a question?
We have not discussed we have not discussed the drilling of the tympanic bone as of now, because I've just dealt with the trans-labyrinthine approach and not really the infratemporal fossa approach. So I'm not really sure if I answered this question.
Okay, Manuel, go ahead.
Yes, okay, for example, Professor, I have a question. So this kind of approach, you can say it's a good approach. What is the frequency of mastoiditis you can have in this kind of approach? and how much is the frequency you can harm or you can make a lesion of the facial nerve, for example?
I would say this depends on your training. If you are trained well, you do a few bones and then get into some cadaveric workshops. I don't think anybody who's unfamiliar with this approach should be doing this without having done about 20 or 30 bones or 20 or 30 skull or heads or whatever, because you should never be damaging the facial nerve. And you should never also be going through the posterior canal wall. I was constantly mentioning to you the posterior canal wall, and there are a few other tips. I can't talk about all of those things in today's lecture, but the posterior canal wall has to be thin, but you shouldn't perforate it, because if you perforate it, then you're in the external ear canal. That should never happen. So the posterior canal wall should be thin, but not too thin as well. So these are some of the tricks. There are a lot of finer points, which, that's what I said. The Trans-Labyrinthine approach requires practice. It's a tedious approach. It's not really as straightforward as a retrocede point. It requires training. It requires knowing how to do a mastodectomy and all that. So that's probably the disadvantage for a beginner. You need to learn to get into the nooks and corners, the transapical extension, the jugular bulb, posterior canal wall, the facial nerve, and then, as I told you, the plucking out the superior ampullary nerve. All these are small, minute things, you know. So, but yes, if you spend enough time on your training, on the bones and the cadavers, you will have no problems. Again, 6.5 years at the Grupo and about 6 months now in India doing a few acoustic neuromas. I've had no problem. I've not seen any mastitis. I've not seen any meningitis. Maybe one case or maybe a case or two cases, you know, but vague memories. But it's not a concern at all. It's not something that we would ever be concerned about. So the patient gets operated and within 7 days, most of the patients are discharged. So mastitis, meningitis, cerebral abscess, these are not a concern with the Trans-Labyrinthine approach if done well. CSF leak, yes, that again, it depends on, you have to see how it is done. You can't learn CSF leak control on cadavers. You have to then go to the next level, that is to follow a master, you know, make sure you learn those fine things, you know. When I was at the Grupo, the first few years, I thought I learned a lot. And then when I went back to practice some of these surgeries myself back in India, I realized that that was not enough, and I had to go and see those small, fine things that Mario was doing, and I had to learn more, you know. So when you actually start doing your surgeries, you then start realizing that there's more to it, and you know how the fat is placed and where are those areas where you plug it in. And CSF leak control is another story. But meningitis is not a problem at all. Infection is not a problem at all with transplant.
So you think, for example, the learning curve of this kind of approach is how much? Maybe 5 or 10?
I would say one needs to drill. Yes, it also depends on. I mean, a reasonably good hand would need to probably work on about 25 temporal bones, and then about 10 or 15 skulls, because you get the CP angle anatomy in a skull, you know. So you need to, temporal bones are fairly easily available. They're not too much of a problem, especially in a country like India, I'm sure, you know, so there's not a problem. But if, and you can get hold of a small temporal bone holder, which will cost nothing. Go take your drills and play around till you get to know the intricacies of the facial anatomy in the Trans-Labyrinthine approach. And then once you are familiar with that gross drilling, you get into the cadaver, the head, and then learn how to get into the nook and corner and expose some of these nerves even better. So yes, it's not a short curve. I would say about 50 dissections before you really master the technique, or even more.
No, thank you, Professor. Thank you.
Okay, thank you. Any more comments or questions for Sampath? Okay, very good, Sampath. Thank you very much for excellent time presentation, and you're taking your time. And thanks for all the panelists for coming. Anything else to say, Sampath? Any closing remarks or?
Yes, the mandate for today's lecture was Trans-Temporal Approaches, Lateral Skull Base. So there are a few other approaches as well. As you see, I have stopped my lecture. I wanted to briefly talk about the Transcochlear approach, which is to have anterior extensions, and then the intratemporal fossa, which could probably be very interesting to all of you. So I guess we'll leave it for another day. We had a fantastic discussion, and I guess we had a long session. And
well, we'll go as long as you want. We'll go as long as you want. It doesn't matter to us, but it's up to you.
May I have some comment, John?
Go ahead.
So I'm totally convenient that this approach, Trans-Labyrinthine approach, is outdated. Sorry to say that at the end of the lecture. But the master of, in my opinion, of skull-based surgeons making now new train to preserve the acoustic nerve, whatever is bad, the hearing loss. So even if you have hearing loss, and even if the patient doesn't hear at all in this ear, we should reserve or preserve the nerve because Dr. Majid Sami in Hanover in Germany talked a lot about the chance that the nerve resolve the problem after some years. So it is very important, in my opinion, to let the nerve in peace, take the tumor out, let the normal anatomy, the nerve, the cochlea inside the patient, maybe the nerve restore the function after some years. And the other point is now the cochlear implantation. The development is taking place everywhere on the world, and those patients have the chance in the coming years to hear again. So you don't need, in my opinion, this approach at all, because with pre-sigmoid approach, with posterior beta-rosectomy, and with subtemporal approach with anterior beta-rosectomy, you can go wherever you want. So I don't know any single indication to sacrifice the nerve at the cochlea for taking out a tumor, because you can really take the tumor from this difficult position through this approach, some temporal approach with anterior beta-rosectomy, and pre-sigmoid approach with posterior beta-rosectomy, or combined approach between the both. So do you have any comment about this?
Yes, so this is the crux of this whole debate, you know. So we've probably come to the crux of the debate at the very last moment before closing the discussion, and I'm glad that you asked this question. So I think the last person in this planet who would want to sacrifice hearing would be an ENT surgeon, isn't it? So an ENT surgeon, an otologist, would probably be the last person to be sacrificing the hearing, even if it means a lot to us to go into the CP angle and remove a tumor if it's illogical. And I was very critical about the endoscopic approach, only because it destroys hearing in an attempt to remove an intrameatal tumor with perfect hearing. So I completely agree that hearing should be preserved at all costs. Now, I think we as both neurosurgeons and ENT surgeons should come together to understand what is serviceable hearing. And I think we have a slight advantage here because we deal with hearing all the time. Now, there are two issues here. In a patient with a very severe sensorineural hearing loss, I'm talking about a sensorineural hearing loss which is seen in all acoustic neuromas, 70 dB or 80 dB. If that was reversible, we would never have had cochlear implants, right?
But you don't know. But you don't know actually if these patient of this lesion definitely reversible or irreversible.
Yes, I'm telling you it's a myth. I'm telling you it's a myth because if let's say that there was a congenital childhood history of deafness, cochlear implants are done to stimulate nerves, isn't it? So the nerve endings, the spiral ganglion. So if the hearing was reversible, now let's not talk about tumors, let's talk about normal anatomy, normal things with non-tumoral causes. If the hearing by any means was reversible, why would the technology be developed in the first place? You would never do a cochlear implantation. These don't recover. Once you have a long-standing sensorineural hearing loss, they don't recover. First. Secondly, I'm telling you, I mentioned this as a part of the lecture, that it's very important to preserve the cochlear nerve, because otherwise a cochlea would also, and this is proven, this is part of the literature, the cochlea undergoes ossification. The cochlea gets its nerve supply. It's a very delicate organ. Just high, and high impact sound damages the cochlea. So the cochlea is very delicate, requires blood. The blood comes only from the ICA, from the cochlear branch, and you saw in that dissection how carefully that it was a very thin artery which was supplying, and we made it a point to preserve it. Now, how often in bigger tumors are we able to preserve it? It's practically impossible when there is a big tumor with hearing loss to preserve the cochlear nerve. So these are the two fundamental reasons. The nerve doesn't recover. I have met Majid Sami. He knows me. I've worked. I've seen his surgeries. I've listened to a lot of his lectures. I've interacted several times with him. Now, Professor Majid Sami in his lecture says that he always makes it a point to preserve the cochlear nerve, because one day he hopes that there would be a technology that would restitute hearing in a nerve that is saved. He doesn't say so, and he compliments the use of cochlear implantation. He said, see, now we have cochlear implantation, and I always told you, preserve the cochlear nerve. This is correct. You must try to preserve the cochlear nerve when it's possible. How often can you preserve it? If you find preserving the facial nerve difficult, cochlear nerve preservation would be really difficult too. And secondly, again, coming to the point, hearing loss that is sensorineural beyond 70 dB, profound sensorineural hearing loss doesn't come back just because you've removed the tumor. And also because, in fact, the hearing will only worsen because of the fact that the cochlear artery is damaged and the cochlea undergoes ossification. So in the beginning, you could probably have so-called hearing preservation. I'm talking about smaller tumors, and which later on worsens. And if you follow these patients up diligently, you will see that a lot of patients end up losing hearing anyway.
Okay. Okay. Very good. Any more comments or questions from anybody? Okay, very good. I'd like to thank you very much, Sampath, and we welcome another presentation on the topics that you mentioned. Anytime you want, actually.
Oh yes, John. Thanks so much. It's been a great pleasure. It's been wonderful being part of your show and the whole platform here. Thanks, John. Thanks, Aip. And I really look forward to another presentation.
Very good.
Thank you.
Thank you. I'm going to stop recording now, but we can stick around and network. Okay. Thank you very much, everybody.
Bye, all of you. Bye, Aip.